Hey, Shelley. Sorry, I'm late.
That's okay. We have got myself, Dan, Eileen Blackstone, Gail, James. I don't know if that's James Cunningham, maybe. John Holmes, Kevin Tossig on the meeting. And I got your draft, so we can just jump into it.
All right. Sorry, I was driving from another meeting and it took me a little bit to get in the house. Okay, so this is our draft PowerPoint slide. I'll do kind of like usual and just kind of buzz through slide by slide. So I think in here I have a little bit of anatomy, but not a ton. And then there are things about different fluids, which I kept pretty minimal. And then some stuff about how to place the IV. So we'll just kind of go through slide by slide. And if we want more or less in some area, you guys just kind of have to let me know. So this should obviously be geared towards EMTs. So the level of, complexity in this PowerPoint isn't great. And it's not, shouldn't be too much overly medical terminology in here. So there's a couple slides related to arteries and veins. And then some of these PowerPoint slides I stole. So these two slides I don't know about capillaries. And then the next one's like bleeding types. I don't know how necessary that is for IV placement, but
I think it's good to include, especially because the audience is EMTs for this.
And then I have a little bit about skin. There's just a couple slides related to skin and the different layers of skin. So really just to talk about, obviously you're going through layers of skin to get to the vessels. So this is just part of the anatomy. And that's kind of all I had in here for anatomy and physiology stuff. So I don't know if anyone has a comment about additional things they'd like to see anatomy wise or anything that they felt like was too much. I tried to keep it fairly minimal for this one. Okay, if not, we can move on. So I kind of just started off with what you need to have. So this is the collection of things you need to start an IV. So whatever IV solution you're hooking up, the set, an IV catheter, and then the IV start pack. And we'll kind of go through some of these in a little more detail in the following slides. So am I missing anything from here that you guys would include on the equipment side?
Container or sharp shuttle?
That's a good idea. The sharp container. Yeah. It's a good add. And then I don't know if we're using the term offsite very much, or if people are using a more generic term.
Morning. My apologies for being late. I just got off another call.
Oh, hi, Kyle.
Howdy.
So my question was offsite versus like tegaderm. I don't know if people are using one term more than the other. Or if
Venagard.
What's that?
Or Venagard.
I was just going to say we use Venagard, but I think equivalent looks fine.
Okay. Yeah, we'll just leave equivalent then. Okay, cool. Okay. So the first part is inspecting the solution, just like any medication that you would give out of a vial or a bag, looking for expiration dates, damage to the bag, the wrong color of the solution, and that the pool tab is intact on there. So all of those things are included in the inspection process. And then administration sets. I didn't go into too much detail here unless you guys think we should about the different drip sets. I just left it sort of as the drop factor might be the one thing that's different between them if you have multiple in your bag.
I think that looks great.
Okay. And then the next steps are preparing the ID bag. So I have removing the tab, closing the flow clamp, removing the protective cap, holding the port and spiking it, and then hanging the bag and squeezing it until it's full. I don't have in here removing the air from it. I don't know if we're commonly always teaching that for folks on the EMT level. If we should put that in here or not.
Boy, I think we should, clearing the air out of the line, because that's a step that they could easily, if they followed this verbatim. I don't know, I'm just one thought here.
Yeah, so I think we could add it. I was trying not to make the slides too wordy, but if we think it's an important point to make on the slide, we should. So maybe clear the air by turning the bag upside down and squeezing the air from the bag into the drip chamber. Is that how you guys would say that?
For minimization, we can put like, keep it more kind of like a prompt for whoever's instructing the class and like just have clear the air from the bag and, you know, teach different methods or something like that. We don't have to have like a whole lot of wording.
Yeah, I kind of like that.
That's a good
From the
idea.
bag. Yeah. Yeah, the instructor should be able to explain that concept. Okay, cool. I like that. And then priming. Anything else on this one? Next one, Shirley. I would say maybe on that last one, Shelley, if you go back up one, the shorter the catheter, the faster the fluid can be delivered, maybe. And then on the next slide, you guys can tell me if you would teach this a little different. Oh, sorry, no apostrophe on patients, Shelley, sorry. Sure, I did that on accident. Autocorrect.
And then on a couple slides before for the selection, it has for needles and catheters.
Uh-huh.
I believe it says needless and catheters. That might be.
Okay, so go back up.
This one?
Yes,
Or
the
the other
two
one?
type of needless and catheters. There you go. Needles and catheters, correct?
Oh, yeah. I think it's supposed to be needle-less catheters, right? Is that what it's supposed to read? Needle-less catheters?
Oh, no. That's a
I
good
know, yeah. I'm not sure. If it's needles and catheters or needle-less catheters. Let's see what they're called. Needle-less
I think
connect.
in this context is probably needles and catheters.
Okay. Maybe. That could be right. So needles and catheters. Okay.
AI says needles and catheters.
Okay.
For whatever that's worth.
That's
Robots in the room.
The one thing I was thinking for this, maybe adding, if the patient has small vaginal veins, you could put maybe in parentheses after that, e.g. elderly patients. Kind of like thinking about it's not
Yeah.
necessarily small, but often like our elderly patient population.
Right. And then if we go up one more slide, Shelley, is anyone using those scalp vein? Do we have those commonly? Like those little butterfly things with I don't know if anyone uses those.
You know, I was going to actually say part of what we were trying to do with this slide deck was to cover EMT venous blood samples, IV access initiation, and the
Mhm.
butterfly ones would be under kind of our probable blood sample, venous
Okay.
blood sample.
Okay.
So I think that is where we would want to include that.
Okay, that's fine. I just want to make sure I'm not putting too many things in.
Now, I think we're trying to combine actually 5 STRs into one training, so which I think
Okay.
is appropriate.
Okay. All right. So if we keep going down, general selection guide. We also ask for them to put larger bore IVs in stroke patients. I don't know if we want to specify that in here. Trauma patients and stroke patients, maybe. Okay. And then I have site selection.
Dr. Rice, do they like a minimum of 18 for STEMIs going to cath or not necessarily? I don't know how wordy we want to be. I'm just, if you think of stroke, I'm wondering, is there an analogy to STEMIs as well, but maybe not.
Yeah, probably. I'm trying to think of which guidelines we specifically. If the chest pain, I think the stroke one specifically lists the large bore IVs. I don't know if the STEMI one does.
Got it.
I'd have to look and see. I'll just double check. So if we're looking at, oops. The stroke, TTTG. There's so many. I don't know where stroke is. Oh. We don't say in here. So our TTTG doesn't actually list specifically a large bore IV, so maybe we don't include it under that one. Maybe we just say trauma then.
Edit out stroke.
Yeah. I was trying to capture the ones where we specifically in the by protocol are asking them to put a large one in, but maybe we'll just say trauma for now. Okay. I have in here call for medical direction for mastectomy side, unless we would just want to say don't put in a mastectomy side. Question for the group.
I would say avoid that side.
Just say avoid mastectomy side. Yeah. I like that too. So I have in here, start sort of distally in case you need to move up. And then the next slide says sort of like in cardiac arrest situations, you want to use a closer one. I don't know if we want to include other things in that, or if we just want to say something more general about versus cardiac arrest, saying something like cardiac arrest patients or other critically ill patients or something like that. Like who would we want a large or a more central, larger IV in versus a hand? I think that's the question.
I like your terminology, which is to say critical patients, including cardiac arrest.
Yeah, so maybe
Goal
change.
is to use,
Okay.
larger vein, such as antecubital, something along that.
Okay.
So about
Okay.
not just cardiac arrest, but
Okay. So maybe change the title, Shelley, to critical patients. And then maybe say in the text for critical patients, including cardiac arrest. Yeah. Okay, cool. Perfect. Thank you. I don't know if you want to include any others in that list. Then we have sort of like factors to consider when you're selecting.
That seems kind of like a busy
Yes.
slide.
Okay, what do we want to take off?
I'm just throwing it out there. I mean, patient preference, I'm not.
Yeah,
I mean, is
Okay.
that referencing like right or left? I don't.
yeah, probably. Or the patient says they always get it on my right, never can get it on my left, or something like that. But yeah, I don't think that's needed. I agree.
What about patient activity?
yeah, I would take that one off.
Yeah, and then maybe we can ditch duration of therapy
Yes.
also.
I'm thinking for the last bullet, then maybe we clarify, avoid if patient has,
Mm-hmm.
avoid extremity with mastectomy or dialysis
Mm-hmm.
fistula.
Mm-hmm.
I don't think most EMS knows the term fistula, but shunt may not resonate, especially at the EMT level.
Yeah, I think you're right.
They just reword that, just delete that whole bullet, Shelley, and just reword to say, do not use extremity that has dialysis fistula or same side as mastectomy.
Yeah, I like that.
Do we want them calling medical direct? I think that's still a little confusing.
Yeah, I think we can delete that. Okay, cool. Thank you, guys. Anything else on this one? And then these next ones just kind of walk through step by step. Oh, sorry, I forgot to fix the pictures on this one, Shelley.
Can you go back up 2 slides? Do we want to have something about cleansing the site here?
Oh, good idea. Where do you want it? Do you want it before tourniquet, after tourniquet?
After tourniquet.
So apply tourniquet, cleanse the site.
I'd almost say going along with what Kevin said, delete that one first photo. The second one seems to be fine. I don't even know if you need 2 photos really.
It looks like it's one photo actually.
We can crop it, I'm sure.
Oh yeah, I see what you're saying. Yeah, it just seems to
I had
be
to do some of the other photos because it was a PDF document that I converted to a PowerPoint, and it took a lot of the photos as like single things. I've had to just crop them. But
we could probably find a fancy AI arm. I'll look at that in the background.
yeah. Cool. Thank you, Shirley.
I'm a snip aficionado.
Mm-hmm.
All right, next one.
Hmm.
Next. And next.
This one also has a lot of pictures, but
Should we add to secure the catheter or line? Or do you,
do you want to go? Do you want to put that on the one up, maybe, or this one? I don't know which slide do you want it on. Chris?
Probably the next slide, like after touch fluid, regulate your flow.
So maybe before you attach your fluids.
I do it after. I typically do it after I attach fluids there to make sure all that's good, and then
Okay.
Yeah, we do the same.
So attach fluids store secure. Okay.
What's the other one?
Secure the IV.
yeah, or what was I thinking? Or dress ID site, or
So secure in place.
Yeah, what's my
Like
train of thought?
secure
Yeah.
IV in place dressing or something like that.
Yes.
Or you say secure IV with offsite or whatever the other language we used it on the previous slide.
Yeah.
Is offsite registered trade?
Or equivalent.
Or alternative.
All right, look okay. Keep going. We'll go down here. One is hematoma.
I was thinking with a couple of these is maybe some pictures to add in just to kind of, especially for the EMT level.
Yeah, I like that idea.
Note. For hematoma.
Yeah.
The one above too, I think. And infiltration. Clotting might be hard to find that, but I think it would be helpful to show pictures of some of these things for EMT level.
Okay. I'm sure we can find some up. Yeah.
There's definitely some AI experts out there.
A picture for this one too, probably, Shelley, maybe. Might be able to find one. Some of these I had to break up on multiple slides because they were kind of long. But
I would say for the EMT side, if there's an infiltration, I don't know that we want them restarting another IV.
okay.
I don't know what your thoughts are for the group, but I feel like if we've got infiltration pre-hospital, I don't know that we want them then trying to start another one as opposed to at this point just getting the patient to the hospital.
So maybe delete this one. Or delete
Uh,
bullet and just
no.
complete transport or something like that.
So I'm just looking at the last bullet. I think the first three are okay. Like we want to treat it, right? Remove it, apply ice, warm, elevate. But I don't know that we want to restart IV infusion above infiltration or in another limb.
Yeah. Okay. So just delete the bullet, you mean? Okay. Great.
Real quick, is there any specific point that we might want to make standard, like I said, for infiltration that might be like, if you have that complication, you must contact ALS, or should we just kind of have that handled through like the local protocols since it's an STR?
I mean, I think the only time we're be using this pre-hospital would be when you don't have ALS available. So I don't think contact ALS would really make sense at this point. It's just treating it and the patient gets to the hospital.
Yeah, and they're usually transporting if they're starting an IV, or they should be.
That's for,
Yeah.
okay, sounds good.
The next one is phlebitis.
I'd add a pick for this one.
Okay. I agree. Okay.
Again, I would take off restart IV fluids in a different limb.
It's a typo anyways. We don't really define hypertonic in this PowerPoint slide. I don't know if we need to.
Yeah, I'm kind of look to see. I don't think they would be eligible to do hypertonics. I'm just looking at the,
Yeah, no, they cannot do hypertonic. And there should be some education on the type of fluids.
that
Well,
is
then-
lower. Yeah, that's lower in the slide
Oh,
deck,
okay. Good.
but I think we can take off the hypertonic part here.
I'm gonna make a note just to
So this whole bullet would go though, you're saying, right, Gail? That's what I was thinking.
Yeah, I think so. The whole bullet, Shelley. Sorry.
Yeah. I think there's one other place we use the word hypertonic. We can,
I think right above, I think the slide above it was mentioned.
yeah. Yeah, so maybe.
Then if we're going to remove the restart on the IVs, on some of the first complications we were looking at, they were noted in there as well. We might need to go back and check those.
Okay.
slide 30.
Yeah, I think they're way further up, Shelley. I'd have to go way back and look.
Okay. What slide do you want me on right now?
Let's go to, we're past infiltration, go to phlebitis treatment, I think is where we're at. Okay. And I don't know about signs and symptoms here, if this is really, those are really accurate for a catheter embolism, but they're usually really tiny pieces.
Yeah, I don't know with this whole slide. I don't want them like
I agree.
applying a tourniquet above it. I'm almost thinking at the EMT level, we just delete this whole slide.
Okay, good. I like that idea. I didn't really like putting it in, but it was in another like base hospital presentation I looked at, and I was like, well, maybe that's something they need to know, but I don't disagree at all. And then again, the word vesicant, we don't really define vesicant, but
You could just say leakage of medications into tissue.
yeah, I like that idea.
Shelley, I got a photo of a pretty cool IV star that looks like a little more human. I'm trying to put it in the chat. It doesn't look like I can put a picture. So I'll just email it to you. I think you can cut and paste it. It looks a little more realistic.
Cool.
Kyle.
Be perfect.
I don't know with this one, like the air embolus. I mean, I think I'm just thinking the EMT level.
Sure.
It starts getting into like pretty complex. I can't see many paramedics identifying this and kind of doing all this acute intervention, much less expecting an EMT to.
Yeah, I agree.
I would probably delete these two slides 40 and 41 would be my thought.
Perfect. Yeah, I agree. I think I'm good with that.
Really curious, just throwing this out there. Have we ever, or the state or any of these training presentations, done a super short video. We're experimenting with 3-minute videos internally at the department, and man, we really have a lot of good success with, oh, it's not 20 minutes, it's not 30 minutes. I mean, is there any thought, not necessarily for today or maybe for later, that we take and splice a YouTube one, or at one of the colleges, we do a short video of something like this where they could see in real time, like, oh, that makes sense. Oh, I see how they're inserting it. I see the angle. I'm just throwing it out there. I don't know if that's a little more time consuming than what we're after or whatever the case may be.
Yeah, it's a good thought, Kyle. I think for these, we just have no budget for filming videos, so.
Fair enough. Hey, Kevin, maybe that's something at the college next time we're around, we could do a 2-minute and cut and paste that and send to the group or Dr. Bradley or whatever, just as maybe a trial or a sample or something.
Yeah, I'd love to try.
Cool.
So I think with this one, I like this, but I think it probably needs a little bit more explanation of, like, when we say circulatory overload, like, what does that mean first, like a definition. So too much, essentially, I think we need to define it first. So maybe a bullet above that. Excess IV fluids administered. What do you think about that?
Maybe in possible causes, we could put heart failure or something like that, or history of heart failure. What do you think? And then neck vein engorgement. I don't know if we want to keep that in there as a general thing to teach. It's not the easiest thing to assess for an EMT. But it is one of the signs. And then maybe rails instead of rails. Shelley, maybe we change that word to crackles. It's probably more recognized. Okay.
Go down a little more.
Yeah. This was another one I wasn't sure we wanted to keep in or not, just because they're not likely to, if they're just the person starting it, they're not likely to encounter this, but
I think it might be a little confusing or maybe not pertinent, but I don't know. That's just one thought.
yeah, it was one that was listed in the other slide deck that I was looking at, but it wasn't one that I was like, well,
Yeah, I think we should keep it more like for like site infection if we're talking about infection. Like I said, this might be a little bit. I mean, any education's good though, but yeah, definitely something. I think that might be beyond them.
so you think we can ditch systemic infection as a complication? I'm okay with it.
I do.
Okay, so maybe delete the next two slides, Shelley, the systemic infection slide.
Okay. 42 and 43.
Yeah. Just to simplify it a bit. This is like a troubleshooting slide. It's a little wordy. So let me know if you guys want to ditch any of this. Maybe get rid of check the air vent, potentially. I don't know. What do you guys think?
I think that's really confusing to the new guy.
Yeah. That might clean it up a little bit. Because they're not going to be giving stuff in glass bottles. So,
If you want to reduce it more, we can probably get rid of the explanation on the check IV catheter. I think that would be a good prompt for the instructor as well to discuss some of the possibilities what happens with the catheter when it's inside the vessel. If we want to reduce more writing, but on that, I think everything else looks good.
okay. What about this discontinued and restarted part? Maybe just discontinued? Yeah, maybe just discontinued and get rid of the last two words.
Yes, I agree. Because this is kind of like a complication, and we were under the complications, we were removing it.
Yeah. And then the next slide is about changing solutions.
Sorry, can we go back to that slide? I'm just trying to I'm reading through it, trying to see.
Mm-hmm.
If it makes sense. Okay. Yeah, it just kind of, I was trying to figure out the wording, but yes, I think it does make sense. Thank you for letting me reread that.
Go down one more.
Again, a little bit wordy, maybe.
Yeah, I don't know if we need to tell them gather necessary supplies.
Okay, yeah, we could take that section out.
And I think we can probably take out the first bullet also, as far because we were talking about like
Yeah,
infiltration
you're right.
and stuff like that.
Yep, I like it. That helps. Cool, that's better.
Do we need to put the reason for removal? Like, I'm trying to think, I don't think most people document reason for removal unless there's an issue, right? If it's just like the care's over and you're taking out an IV.
Yeah. Yeah, we can get rid of that too.
Just that one.
I don't know if they document any of that though, right, Gail?
I'm trying to think,
Or STR,
EMS is-
it should be documented that it was an STR utilized by the EMT, and then the time and or the rest of the information will be required as part of the PCR when they input that. But per statute, we do state that they do have to document it.
But if as it's inserted though, this is removing it. Like, do we need to document all this when they remove it?
I would say yes for the timing and being a complication. You don't have to. I think it would be good information though to include.
Okay.
I kind of like the wording of what Chris just said, though. Maybe if complications, document. I don't know about, I'm just thinking of time constraints and everything about documenting the time you pull it off. I guess maybe it's better, but I don't know.
I agree with you, Kyle. Yes,
I think
for complications.
I think the one thing I would say is that the STR is being used for EMTs probably the vast majority of the time for IV is in the hospital setting. So for a lot of ED techs or EMTs, and in the hospital setting, at least, that is where we would document an IV being removed, right? So I think that's kind of like this whole training is a little bit covering both pre-hospital and hospital setting.
Yes.
So do we want to just put, instead of if complications, maybe go back to what you had, Shelley, and just document?
Or document as required.
Yeah, or
by
just
something like that.
document time removed, catheter integrity, and if complications were present.
Yeah, that sounds good. I think so. Because especially even out in the field, I don't see them removing a catheter
Yeah.
unless it's a complication.
Yeah.
So I think that's good to cover both roles.
Yeah. And then the one below, the general documentation requirements, the next slide.
Hey, Dr. Bradley, quick question. I was listening to what you said about the thought of like ED techs or whoever doing this. Is the thought that this replaces, God, I'm dating myself, the entire EMT intermediate or IV class? Or is it, hey, EMT, you went through this, or intermediate IV tech, you went through this, and now we're just documenting the procedure of actually starting the IV? Is that a clear, am I asking a confusing question? I'm just wondering if I'm just the EMT off the street, is the thought that we just give this 52 slide presentation and they're good to go?
No, so the background is we are required at the state to have training on anything that is a STR. That does not mean that anyone is going to use any of the training, although we have really tried to get away from, there's like a 300-page outline that is currently the quote education for STRs. We have, as we've eliminated STRs, kind of come down to a relatively small list, and the education committee has been plugging away kind of one at a time, trying to create very well done PowerPoints that someone could use. This would not replace any original education. This would be if an agency now wanted to have EMTs doing IVs, they would have to have training provided as the agency, and their medical director would have to approve it. So this would hopefully be for those agencies. For the hospital setting, I know most hospitals already have their own training curriculum, but if it's a small, maybe critical access hospital, they may not. They could also utilize this training. So this is really to fulfill the requirement of STR training and kind of approval by medical direction to perform these skills, if that makes more sense.
Yeah, but so I guess and I appreciate, I'm just trying to understand the true historical thing of this. Old school, right? You had to go through the quote intermediate or IV class. Does this not then, if as an agency director here, I say, okay, we're going to have our EMTs start IVs, and our medical director says, cool, that's great. Is the thought that we could just train this, of course, in the seat, in person, this 52 slides, and no other background on what type of fluid, what it does, blah, 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 and they would be good to go? Are we trying to make it, is it that simple? I'm just trying to understand the historical perspective, and if that's really all it is.
If I can speak on the process we utilize when I teach it, we use so anything we get from ADHS we use as like the minimum education required when we give the classes, and of course we add on anything to it. This is an STR that we do teach ourselves and we control because of the severity of it. So we go out, we teach the class, we do a stick with them, all the trainings. They have also, of course, have to go through like the skills test exam as well. And then they have to acquire at least 5 sticks in the field within the first 30 days in order to kind of get released on it, on that portion. And we include, like I said, the fluid education as well, the types of fluid, how it travels to the system, osmosis and diffusion, all that other stuff, as required by our medical director. So that's kind of like that point for anybody that wants an EMT to be able to do this STR, that medical director can set the standard as far as being released, if you will.
Gotcha. And the state doesn't mandate X number of hours to do this to be able to then get cleared by the doctor and the agency? Maybe that's a question for Dr. Bradley.
No, there's nothing in rule.
Gotcha.
We just, yeah, all it says is that you have to have training. STR is defined very clearly in rule, which means you have to be training approved by your medical director to perform these skills.
To Chris's point, has there ever been a thought, or should we add something about getting X number of sticks or any mention of a clinical setting prior to being able to do this? Merely throwing it out there. I don't know if that's a
We
hindrance.
can't, yeah, we can't do something that's not required in rule. So if rule doesn't require it, we really can't require that. We'll put that
Gotcha.
in here.
Okay, gotcha. Thanks.
Yeah,
Just-
yeah, no, it's a great question. That's really where the importance of medical direction involvement is. This is kind of defined as a training tool, but hopefully medical direction will then say, well, in order for you to actually do this, we want you to demonstrate competency.
Gotcha.
I'll go down one.
This was just an example. We don't have to include something like this, but
Different documenting it on an EPCR, right?
There'll be different type of systems for documentation.
this is like the narrative example. Most of the time they'd be using also a drop down to put in the,
Yeah, each component.
The only thing I like it, the only thing I might take out is the actual time, because everyone does timestamp it with the drop down, and the latest is that from what we're getting from PWW and whatever is that you probably shouldn't have specific times in a narrative merely because the provider is accidentally
Right.
probably going to create error.
yeah, agreed.
So, sorry, I'm going to have to jump off for 11 o'clock meeting. I'm going to put it in the chat. When we had formed the work group, we kind of talked about creating 5 combined, and I'll put what those 5 are. One of which includes ultrasound, paramedic IV initiation with ultrasound, but I don't know that we have all of that covered. So we may need to have another work group just include some of those additions, but I'll put all the ones we had initially voted on including in this.
Yeah, I think I have a draft of the in ultrasound one, but I'd have to look for it again.
And that one can maybe be a separate one that we can do versus the because the other 4 are all EMT specific.
Okay, thanks, Gail.
Anything else for the example?
Mm-mm.
Moving down. Looks like you have a slide for each of the fluids except for D5W.
Yeah, I was trying to remember if they're allowed to infuse that one.
I
As I was-
think that was this Jason. I think that was taken off sometime this year.
I think so too. So I think we can probably take off D5W off of that.
Should we include some education on the isotonic fluids as far as, and then hypertonic and hypotonic, so they know what they are in between calloid, crystalloid?
Well, maybe we just put it, because they're not going to infuse any of that. So maybe we just take that off. So on the next slide, Shelley, if you just take off, just put solution of sodium chloride in water, just take off the word isotonic. It doesn't really mean anything to them. Yeah. Okay.
All right.
I don't know that it's a real big source of calories.
Push fluid and restore.
I'm gonna look up how many there are in there.
And I would also the first bullet just say source of water and electrolytes instead of calories. I don't think anyone is using this for calories.
No, there's only 9 calories in lactated ringers. I just Googled it.
And one almond has more calories.
That's funny. And then again, liver disease, I don't know that we need to include that on here either. I would give it to someone with liver disease, so I would delete that.
Is it a
OB.
true contraindication for CHF?
No. I think
Well,
it's just
you worry about the word contraindication, right? That just always scares people. Oh my God, I absolutely can't do this.
yeah. So why don't we just take off the word contraindication and just make the bullet say use with caution and instead of calling it a contraindication. I think the slide above it has it like that too. We might want to change that one.
All right.
Thank you, Jelly.
Down one.
So when we're talking about, so if you look at Gail's text or her chat, the one thing we also have to include in here is maintenance of non-medicated IV fluids. So sorry, I think we're down at the end, aren't we, Shelley? Yeah.
Yeah.
So do we need, what other slides do we need, or what other things do we need to put in for that maintenance of non-medicated fluids? And what do we need, and what slides do we need to put in for EMT venous blood sampling? Those are, I think, the things that we don't have probably enough content on in here.
When would Service X be drawing blood?
They don't often, but it's in the scope of practice. So that's why it's an STR.
They use it a lot in the clinical setting.
Got it.
Yeah, certainly in the hospital, they do it a lot. In the field, much less often.
I guess I forgot the hospital. That's true.
Yeah.
Then in the field, the only times I would see maybe would be for like hazmat teams, maybe to get a blood draw before any administration. But yeah, it won't be used too much out in the field for the sampling. But yeah, mainly hospital.
So let's come up with the slide titles we need for maintenance of non-medicated IV fluids, and then we can fill out the content. But let's think of which slides we need to include. Just sort of like Googling stuff. There's stuff about like how long things can be hanging for. I don't know.
Yeah, flow rates. I'm trying to get the rest of the stuff in the, how to
Okay.
adjust. Yeah, some of the education is there, like in the little piece, in like each little piece.
Yeah.
As far as the maintenance, but yeah, we should probably.
So we need a slide on adjusting flow rate. So maybe that's a slide.
So it's like what they mean, like bolus versus to keep open, keep vein open, the different terms and what they mean, the purpose.
And do we want a slide that's like how to actually set it up, like something that the bag needs to be above the patient, and so they're not hanging it on the ground, or tubing, and any of the Y connections or anything like that, like basic
Yeah.
equipment.
Yeah, exactly. So do we say, what slide would that be? What would we call that?
IV setup, maybe.
Yeah. Do we want to put that up where we
infusion,
have,
infusion setup or
yeah. Trying to think of, do we want to put that up where we have like after the bag setup? So priming, so start right there, Shelley, like 13, 14. Keep going down now. And then keep going, keep going, keep going. Keep going. No, I think it's way down, sorry. Go to, yeah, keep going.
Okay.
Ooh.
Before complications.
Yeah, maybe. What do you guys think? Do we want it here where we say, or do we want it
Yeah.
down lower, the maintenance of fluids section?
I would say after, because it looks like this right here is complications of the actual insertion
Yeah, I agree.
versus running an infusion.
Okay, so maybe go down more. Maybe it is kind of at the bottom. This is like, yeah. Extravasation, circulatory overload. So maybe here before above changing the solution. Oh no, wait. No, keep going down. Removing IV documentation. Types of fluids. Yeah, maybe it is just at the bottom that we say we start the section for maintenance of initiation and maintenance of fluids or something like that. And then we need a slide on. So what do we want to say here? What do you guys think?
It depends if you want to break it down as far as like setup, like the I don't know how you'd word this. I'm terrible at wording, but that
Yeah.
how you would hook together the connections, that they, you know, make sure they're clean, that they run the fluid through so that a bubble doesn't come through the line, and then having the bag hanging above their head or above, you know, or above their heart, whatever, however you want to put it.
We can say, because up there we say we have them prime the line. That's kind of where it ends. Prime the line and hook it up. And then we say, maybe this slide is.
Something about like back pressure.
Yeah,
blood
say,
through.
say something like, instead of ensure fluid is running above patient, say, ensure that the bag is hanging above the level of the IV that's placed
Yeah.
to prevent backflow of blood into the IV. What else? What other points?
Do we need anything about spiking the bag? Or, I mean, it seems pretty self-explanatory, but do
Yeah.
they need
Well,
instruction on that?
That we have above, Jason.
Okay. Okay.
Yeah, that there's a.
Calculating maintenance rates just for the fluid.
So maybe new slide. Shelley.
Okay.
That says adjusting the flow rate or something like that. So call this one adjusting the flow rate. And then I don't know what we need to put in here about, you know, select the appropriate drip set. Right? And then I don't know if we want to put in here the different, I don't know what you guys are typically carrying or I don't remember what's required to be carried.
Mostly out in the field, I see are like the 20s and 60s.
Yeah. Do we want to list them and like list the ones that you'd use for pediatrics only, or?
There's the adjust the flow also that I've seen out there a lot.
Okay.
Well,
Okay. Hmm.
yeah, give them education on that, on drip sets.
Yeah,
far
so maybe, yeah, what are we gonna put in here for drip sets, so?
Do we need to defer to what the DHS reg is for ambulance inspections on those? And maybe we don't, because it could be confusing for hospitals. I don't know. I'm just throwing.
Yeah, I mean, I was thinking that, but yeah, I think it could be.
Yeah.
I'm trying to
mean,
be clear here about just explaining what a drip set is.
Sure.
And I don't think it would change as far as what's already there in the standard, because that should just be on the ambulance period. Some these items. So I think it would kind of be the same thing. The only other type of drip set I see here would be like the blood, but this being an STR, I think we kind of want to stay away from that.
Well, I think I could put together some slides, Shelley, for when we do the next one, but let's have a slide that has, so this slide is going to be, instead of adjusting the flow rate, put how to select the right IV drip set. And I'll make a slide on this and talk about the drip chamber, the calibration, the tubing length and extension sets, that kind of stuff.
I'm going to send you some photos, Shelley
Okay.
and Dr. Rice, of the different tubings so they can see it. I think that might help a visual.
Yeah, I think that would be super helpful. And then we can talk about, and then next slide will be situational selection. And then we'll have, like, the ones will be like trauma, shock, burn, medication, and this is non-medicated. Trauma, shock, burn, pediatrics, routine maintenance fluids. And those would be the three things. And then
Trauma, shock, burns. What else?
yeah, trauma, shock, burns, pediatrics, and routine maintenance of fluids. And I'll fill that slide out. And then let's see here. Let's see. What else do we have on this? So that's probably good for selecting the drip set, and then maybe make a slide on like, I don't know, patient monitoring or something like that, where we kind of talk about, or patient reassessment, do like patient reassessment. And we'll talk about avoiding fluid overload, continually reassessing the patient, checking blood pressure, and listening to lungs. I'll have to reword all this, but. And that might be enough for maintenance, right? Other than these things, would you guys include anything else?
The bolus rates, the bolus calculation, maybe.
For like,
And then are we gonna put an age limit for EMTs doing, or is
I don't think statute
outpatients-
has an age limit. I don't think statute has an age limit. So individual medical directors, I know oftentimes they'll say not under 6 or not under whatever age EMTs, but it's not in statute, so we can't prescribe it here.
Okay, so we'll leave it on the medical. Sounds good.
Hey, Dr. Rice,
Yeah.
what about a slide? I didn't see it in the beginning, but that not to delay care to establish. So for example, like we do like 8 to 10 stroke alerts at Estrella a day, and the first CT scan is a non-contrast, so they don't necessarily need to have an IV. I would hate to have them sit on scene trying to get an IV for 10 minutes before moving if it was a stroke or STEMI and they were just a BLS crew. Time's kind of more important than that line.
Yeah, maybe we put that up earlier in the slide deck. Trying to think of where that would go best. Let's see.
Still hung up on I can't spell reassessment.
No, I think maybe where we have the initiation and maintenance slide that the first one we put in there, Shelley, maybe that's a good place to put that. Where we say, wherever that one is, where it says, yeah, ensure that the bag is hanging by the, but maybe a bullet above that that says, if initial attempt at IV placement is unsuccessful, do not delay transport for continued attempts. Right? Is that what you guys are saying?
Yeah, I'm just thinking that, I would want them to, wherever they're at, delay transport because they're trying to get an IV.
Agreed.
Stroke or STEMI, just, hey, move the patient. That's better.
No, exactly. And it goes for lots of things, right? So we know that, like trauma care, yeah, we know that on-scene times for trauma care are longer if EMTs are placing IVs in people. So we know that there are situations that occurs. So yeah, I agree.
Yeah, serious or unstable condition, just move patient. Don't delay for an IV, try in route or something.
Yeah.
On that remark as well, doing the IV class just gives them EMTs the ability to do that skill. Some of these calls they shouldn't be transporting anyways. That's beyond their scope, like strokes, STEMIs, level 1 traumas, things like that require ALS transport. So I don't know if we're
Well, some places don't have ALS transport.
Yeah, I was going to say in our
Hopefully
area
it
we
isn't a
have several.
requirement. Yeah.
Right, several other communities they have one ALS ambulance, and when it's gone, everything else is BLS, and yeah, so yeah.
okay. Yeah, makes sense. Okay, cool. And then the hospital also. Yep.
Yeah. And then EMT venous blood sample. So what do we need for that? Something about tubes, right? We could put.
And on this one, are we going to on the blood sampling? Are we going to keep it on either like utilizing, like you said, for a stick for specific for blood draw, or on the initiation of their IV, where like most places, if it's an established IV from someone else, even they're trained, they don't utilize an existing IV for blood draw.
Right. So the 3 bullets on this slide, Shelley, would be straight stick for venous blood sampling, venous blood sampling with initiation of or with placement of IV, or venous blood sampling from pre-existing IV.
So
Right.
there's 2 varieties. Okay.
And then from the second bullet is blood sampling with initiation of or with insertion of IV. That's yeah. And those are 3 separate bullets, Shelley.
Oh,
Because they already have an IV in and we have to explain the difference between taking it right off the IV you just started versus taking it from an IV that's already in. And then they can also do a straight stick potentially with a like butterfly needle. So then we'll need a slide for each of these probably.
what text for the straight stick for venous blood sample?
Let's see, we need probably a picture. I don't know if there's any specific, what would you guys say for this one? I don't do these very often, so.
Maybe something about locations for like where they would get the straight stick from. And then landmarks, things like that.
And yeah, additional equipment,
So like vacutainer,
accutainers, yeah, whatever equipment they're going to utilize for the draw.
And I don't know if it's worth doing a separate slide, but you know, showing a picture of each of the little vials or something like that. And that's something about trying to prevent it from hemolyzing. I don't know. Just some of the things that I've seen that they have problems with.
yeah. Yeah, I may need to work on these little offline, Shelley. Once we get the titles, because there's a bunch of stuff I need to put in here for the vacutainer, hub and adapter, putting some pictures in.
Right. And how you have to rotate it, you know, to
Yeah.
flip it upside down and back. And
Yeah, I'll have to kind of go through that.
No, but yeah, we'll have to give like the general education for drawing blood.
And then another slide after this, Shelley, will be like safety considerations. And this will include things like sharps and labeling. We'll put that on the slide so I remember. Sharps, labeling, contamination prevention.
Waste.
Yeah. Let's see, aftercare, a slide on aftercare. We already did complications. Yeah, I think that should be enough for these. So that's the maintenance, that's the venipuncture one and the maintenance of IV fluids one. And then we need a set of slides for ultrasound guided IV, but I think we're going to do that separate because that's a paramedic STR.
Yeah.
So maybe we do this separate slide deck. So maybe the next time we get together, because we're running out of time today. So the next time we can go over, I'll add all this stuff into the slides that we just talked about for these couple things. And then we can, on the next time we get together, we'll review those new slides and then the ultrasound IV slides. How's that sound to the group?
Sounds good to me.
Okay, cool. And then Shelley, will you just send me the draft you have and then I'll fill all those new slides out that we made and send it back to you?
Sure.
Cool. Okay, anything else on this currently? So I think we're running out of time to do much more today, so.
Agreed.
Cool.
Yeah.
All right.
good
Well,
progress.
yeah, I think we did good. I think we've got what we need on the title slides for those things. I'll get that back out to Shelley and then we'll find a time to put one more of these together to finish these up.
Okay,
That's-
one more work group.
Yeah, perfect. I think so. I think we can do it in one more.
Great. Thank you, everybody.
Yeah, thank you guys very much
All right,
for your.
thank you.
Thank you, everyone. Have a good day.
Thanks.